Okay, so this is the final one. This is a respiratory examination with Harry. Hello, Harry. I'm your dad.
I'm your son.
Good lad. Do you mind if I examine you? Okay. So the first thing we do is stand back, and it's always inspection. So have a little look at what he's doing. See what the breathing is like. Is he nasally flaring? Is his mouth open or closed? Can you see any recession which is happening over here? This is suprasternal recession. This is supraclavicular. Have a little look around the sides as well if there's any presence of scarring or of nicotine staining on the hands. And just the general state of what the breathing is like. Is he panicked? Is he relaxed? Is he quiet and breathing comfortably? And you should be breathing abdominally, so that's where the tummy moves in and out, and the chest actually stays nice and still, and that's for diaphragmatic rise and fall. Next thing, take a look at the hands. So have a look at the hands, looking for clubbing, looking for cyanosis, nicotine staining. Roll the hands over, feel the temperature of the hands as well. Always compare left with right. You can mention if you want to about koilonychia, that's with iron deficiency anemia, and perhaps that could present with some shortness of breath. Next thing, pop both hands out in front of you, Harry. Cock your wrist back. This is looking for a CO2 retention flap, and there's not one present there. Just pop your hand down there. It's very important that you always feel the pulse in a respiratory examination. If the patient is presenting with shortness of breath, it may be secondary actually to an arrhythmia, so you can just time it. Next thing, walk all the way up the face. The next thing you come to will be to the neck. And this is looking at the JVP. And the JVP is quite important in a respiratory examination because of Cor Pulmonale, and this is long-standing respiratory disease due to cardiac problems. Next thing, look in front of the eyes. So look over to the left, Harry. Again, just looking for anemia. Moving down to the nose, checking for cyanosis. Whilst you're standing here, you can feel the anterior cervical nodes. And finally, looking at the JVP. So you don't want to be looking at that. That actually is the external jugular vein. We want to be looking at the internal. One way of making it slightly bigger is obviously do the hepatojugular reflex. That's where you press on the stomach and it will rise. Whilst you're in this position now, you can move straight down onto the neck. Two fingers feel on top of the trachea. So when we've done inspection, now we're moving on to palpation. Palpation takes four things into account. The first is the trachea. Is it deviated? The second thing is we're going to do tactile vocal fremitus. The third thing is that we're going to do right equals left expansion. And finally we're going to check for the apex beat. Because the apex beat is the fullmost part of the ventricle, and of course it's contained within the mediastinum, so if there's mediastinal shift, the apex beat will move laterally. So if I just do those in order, feel for the trachea, just pop your hands down by your sides. Secondly, big breath in and out. Good lad. Say 99.
99.
And again.
99.
And again.
99.
And again.
99.
And again.
99.
Good lad. And again.
99.
And you're feeling for the border to feel for any vibration sense around there. Next thing, apex beat. Find the pulse of maximal impulse, and then you count down on the rib margins, and the apex beat should be in the fifth intercostal space midclavicular line. And those are the four things on the front of the chest. Next thing, you're moving on to percussion. You can percuss directly over the top of the clavicle, but it's not a particularly nice thing, so I always tap over the finger. It should be resonant on both sides. And as you can see, I'm just comparing left with right. Lastly, inspection, palpation, percussion, auscultation. Listen. Don't forget to listen over the apices. And then as you're listening, just move methodically, making sure that you're listening in the sides. And if you listen to my command, it's nice and clear. Take easy breaths in and out through an open mouth. Good. Now we've done everything on the front, now I want to move exactly to the back. So if I just get you to turn around slightly there. Exactly the same again this time. First of all, just take the opportunity to have a little look on the back. You may see just in the midline, site of a previous chest drain insertion. Look for scars, particularly a pneumonectomy scar, which is kind of a J-shaped incision, or anything that could give deformity of the spine. Sometimes a kyphoscoliosis will change the appearance of the chest. Same again, if I just turn you right the way around, you sit yourself on there now, so everyone can sit at the back. Hands either side, bring him in, big breath in, and out. And in, and that's checking for expansion. Next thing, say 99.
99.
And again.
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 99.
Good boy. Next we're going to tap down for percussion. Percussion should be resonance. If you've got a collapsed lung, it will be hyper-resonance. If you've got a patch of dullness, such as in a pleural effusion, it will be stony dull. Lastly, we'll have a listen. Same commands again. Gentle breaths in and out through an open mouth. A little easy. Just cough, mate. Okay, it's gone. Sometimes you can hear things on the chest, and actually, you just get them to cough, it disappears, and there's a little patch of wheeze there, it's gone. Okay. Swing yourself down the front. That's the examination over with. You always thank the patient for examining them, and a very simple bedside test that you'd like to do in a respiratory patient would be to do a peak flow machine reading. You may want to go off and do formal spirometry, and you may want to get a chest x-ray. And that's the end of the exam.